Thank you, everyone. Thank you, Dr. Jom and the Hospice team for inviting me for this talk. So, after all the sessions in the morning, I would start with this topic. This is a bit advanced topic, managing of multi-drug resistant organisms. So, I would try to simplify it as much as possible. So, the topic here we start, managing multi-drug resistant gram-negative infection. So, I will just start with a disclaimer, just like how the mutual fund advertisements and all goes. The newer antibiotics mentioned in this presentation are highly prone to emerging antimicrobial resistance. Few of them are really expensive. However, using them does not guarantee you success always. Using them without proper indication might land you in the prison of pan-drug resistance. So, beware. So, I will start. I don't have any conflict of interest and I have taken some slides from some of my friends. Starting with the definition of the topic, MDR or multi-drug resistance is the antimicrobial resistance shown by a species of microorganism as acquired non-susceptibility to one agent in 3 or more antimicrobial categories. So, if 3 different categories, so say 1 beta-lactam, 1 aminoglycoside, 1 quinolone, if 3 things are non-susceptible, then you can label it as a multi-drug resistant organism. Whereas there is XDR, that is extensively or extremely drug resistant organism, it is non-susceptibility to one agent in all but 2. So, that means only 2 classes of antibiotics are susceptible for these organisms. So, that is called as XDR. There is a PDR category also which is defined as non-susceptibility to all the agents in all the antimicrobial categories. So, this is the basic of MDR, XDR and PDR. So, this will be the key players of the day which I will be discussing: Escherichia coli, Klebsiella pneumonia, Pseudomonas aeruginosa, Acinetobacter, Stenotrophomonas and Burkholderia. So, these are the common organisms that we see in our wards and ICUs which are gram-negative and has much potential for drug resistance. Coming to the resistance mechanism, you might be familiar with this classification, Ambler classification. So, they classify it as class A, B, C and D. So, class A basically we will say is ESBL, class B is metallobeta-lactamases or the most common is NDM, class C is AMC and the class D is OXA. So, these are the resistance mechanism which I will be dealing with later. It is not only this beta-lactamase mechanism, there are other mechanisms like porin channels, efflux pumps etc. for drug resistance. So, this is mostly theoretical part. Now, we will start with how much drug resistance is there is our place, that is Kerala. So, fortunately, our state Kerala has published its own antibiogram or antibiotic profile. So, this was published 2 months back and so it had some very surprising findings. That is in Kerala, if you take the of all the E. coli strains that were tested in the medical colleges and the hospital that were enrolled, 67% of them were ceftriaxone resistant. Klebsiella, if you see, 71% were ceftriaxone resistant. Pseudomonas is intrinsically resistant to ceftriaxone, so they tested ceftazidime, which was 52% resistant. And if you go for carbapenems like meropenem, imipenem, E. coli, it is relatively okay, only 10% resistance was there. But if you see Klebsiella, the resistance rate was 43%. Pseudomonas, it is 14% to carbapenem. And if you see Acinetobacter, the resistance is 47%. So, the resistance rate of the antibiotic that we very commonly use, that is ceftriaxone, carbapenems etc. are very, very high in our state of Kerala. So, this is about Kerala. So, Klebsiella and Acinetobacter 50% resistance to carbapenems. If you go to the Indian scenario, the scenario is worse, I would say. In E. coli, the carbapenem resistance, this is from the ICU strains mostly, and carbapenem resistance was 58%, Klebsiella resistance 72% in various studies. We have the ICMR data also. So in ICMR data, this data are almost all over India, the data remains almost similar, I would say. So you take E. coli. Over the years, another thing that I would like to highlight from this slide is over the years, the susceptibility is reducing. In 2016, 60% of the E. coli strains were sensitive to piperacillin, whereas in 2021, it became 47%. So the susceptibility is reducing over the years. 80% meropenem sensitivity was there in 2016, whereas now it is only nearly 70%. So same is the case with Klebsiella, where the susceptibility of piperacillin is only 33% in India. And if you see meropenem, the susceptibility is only 45%. So most of these reports by ICMR is quite shocking, because these are the antibiotics that we use very commonly in our place. Piperacillin sensitivity is 73% in Pseudomonas in 26 in blood samples, whereas meropenem susceptibility is only 66%. And fortunately, one drug that will work in our scenario that has showing some susceptibility is colistin, which is retaining around 97% of susceptibility. Acinetobacter, again, I just showed this slide to show that the number of drug resistant cases in our country is ever increasing. So unless we keep a check on our antibiotic use, this is going to a doom-like situation in the coming years. So as we saw in the previous slide, in most of the colistin was sensitive. So then can we give colistin to these cases? So the problem is, you give colistin in a pneumonia case, the lung concentration is always poor. So you can't exactly bank on colistin for treating ventilator associated pneumonia cases. As you all know, there is a high risk of nephrotoxicity for colistin. In critically ill patient, there is risk of neurotoxicity. And colistin is something that has got rapid renal clearance. So the problem is whether it will achieve the adequate therapeutic drug levels is still questionable. The possibility of colistin attaining a steady state is questionable in many cases. So just like colistin, we have another drug which is polymyxin B. The colistin is polymyxin E. So polymyxin, the risk of nephrotoxicity is comparatively lesser, but the penetration to the renal tissues, urinary excretion is lesser, so you can't, it is not there. So you can't give polymyxin for urinary tract infection. Cost wise, it is almost similar. So from this, the take home message would be that colistin might not be, even though susceptible, it might not be a good drug in our scenario due to the poor lung penetration and very high risk of nephrotoxicity. So this is one drug that we commonly know, meropenem. So carbapenem resistant, so I am working in a government medical college. So the thing is that many of the newer things are not available. So many times we might turn helpless. Even if we know that meropenem is resistant, we might have to give meropenem. So this scenario arises often. So are we doing justice to the patient? Can you still use? It is not like it is a 100% no. So you give meropenem, always you try to take advantage of the time above the minimum inhibitory concentration. So you give the drug as a prolonged infusion, then it might work, because if the time above the MIC is kept as a constant, then it might work. Meropenem can be used in combination with drugs like colistin and tigecycline, and even there are strategies like giving meropenem ertapenem together. This is especially for the resistance mechanism KPC, where this strategy also might work, for which we have some evidence of double carbapenem therapy. But these are only few special situations where you can use this combination. And going to meropenem, the next would be, is there an oral carbapenem? So our first go-to answer would be pharopenem, which is actually not a carbapenem. If you ask me, is there any oral carbapenem? Yes, there is this agent named tebipenem. It has not reached our country yet. So this has been tested good in complicated urinary tract infection. So tebipenem is an oral carbapenem. We look forward to this drug in the coming years for treating urinary tract infection. So coming to my topic proper, how do you treat these cases? So this is my first case, 55-year-old male diabetic with fever, flank pain, dysuria. Patient presented in shock, and cultures, blood and urine culture showed E. coli, which was resistant to ceftriaxone and was showing sensitivity to piperacillin, tazobactam and meropenem. Straightforward question. So what is the treatment? So what is this strain called as? So for practical purposes, if you see ceftriaxone resistance in an E. coli or Klebsiella, you can label it as extended spectrum beta lactamase, that is ESBL. So what is the treatment of ESBL? So recently a lot of guidelines have come in this aspect. There are ICMR guidelines, there are IDSA guidelines. So you can treat them like this. If it is sensitive, in case of cystitis, if it is sensitive, you can give agents like nitrofurantoin and cotrimoxazole. In pyelonephritis, so this is a take home point. So in pyelonephritis, there is no role for nitrofurantoin. It has role only in cystitis because it's a drug that will be completely excreted in the urine. There is no role for nitrofurantoin in pyelonephritis. So if cotrimoxazole and levofloxacin are sensitive in this ESBL, you can give that. If it is resistant, the recommendation is to give carbapenem or meropenem. Infection other than UTI, for that is ventilator associated pneumonia, bloodstream infection, if it is an ESBL, that is recommended, the treatment recommended will be carbapenem. So where did our piperacillin tazobactam go? Should you give piperacillin tazobactam in ESBL? The answer is this trial that I have highlighted, that is Merino trial, which was published in 2018, where there was a higher mortality in use of piperacillin tazobactam in ESBL cases. So the recommendation is it is not suggested for infections outside urinary tract infection, even if it is susceptible. So the message is that ESBL organism outside the urinary tract, even if the piptas shows susceptibility, you are not supposed to give that drug. There will be a high risk of mortality. Coming to next scenario, 57-year-old female presented with fever, right flank pain, burning micturition. This I would say a simpler scenario. Organism that was grown was Enterobacter cloacae, and this was showing sensitivity to ceftriaxone. So the patient was started on ceftriaxone as per the sensitivity provided to the doctor, but there was no clinical response after 3 days. So what is this mechanism and how do you approach? So this mechanism, this peculiar type of resistance mechanism that we call as AMC. So there are different types of ampicillin AMC. So it is peculiarly seen in these organisms that I have highlighted, that is Enterobacter cloacae, Klebsiella aerogenes, Citrobacter frondi. So in these organisms, the lab report will show ceftriaxone is sensitive, but if you treat with ceftriaxone, there will be possibility of induction of AMC, and the net effect will be there won't be clinical response in these cases. So AMC beta lactamases, how to treat? The problem is that there is no recommended mechanism by the CLSI standard guidelines to know whether this is an AMC or not. It can be tested by genotyping methods. Certain drugs like ampicillin, amoxicillin, first generation cephalosporin, etc. will induce this AMC. So even ceftriaxone, I would say, is a weak inducer of AMC. But if you try to treat an Enterobacter or Klebsiella aerogenes with ceftriaxone, there is a risk of failure. These cases, cefepime is a very good drug in AMC producers. And if the cefepime MIC is more than 4, you can give meropenem. Again, just like the previous scenario, I would say that piperacillin tazobactam is not a suggested agent in treating AMC beta lactamases. So these are some scenarios. I showed this because these are some scenarios where your lab report will show, okay, this is sensitive, but you are still not supposed to give those drugs. If it is cystitis, you can give nitrofurantoin and cotrimoxazole. These things works. Next scenario, I would go to a complex scenario. This is a scenario of ventilator-associated pneumonia, where the blood culture was showing Klebsiella pneumonia, And if you see this resistance pattern, almost everything is resistant except colistin. So meropenem is resistant, imipenem resistant, ceftriaxone, cefoperazone, all are resistant. So this is a carbapenem resistant enterobacteriaceae, or we abbreviate it as CRE. So everything is resistant except colistin. So how do you approach these cases? So the guidelines say there is a huge lot. I am not going into much detail. If it is urinary tract infection, things are simpler. If it is a cystitis, give things like nitrofurantoin or cotrimoxazole. So the message is that cotrimoxazole is a very good drug in urinary tract infection. If it is showing susceptibility, you can give that. There is no need to hesitate giving cotrimoxazole. If the infection is outside the urinary tract, things are complex. So because cotrimoxazole might not be that great in such things. So if it is a carbapenem, if the meropenem is showing resistance, nowadays the best agent in Klebsiella and E. coli would be ceftazidime avibactam. So this will take care of resistance mechanisms like KPC, OXA. These are carbapenemase mechanisms in India. I would say if you take all the carbapenemases, 50% the resistance mechanism would be something called as NDM, that is New Delhi metallo-beta-lactamase. Around 45 to 47% would be something called as OXA. So NDM and OXA are our common mechanism. Out of this, OXA will be taken care of by ceftazidime avibactam. And if it is an NDM, the drug of choice would be something called as aztreonam. So you give a combination, even if you don't know the exact resistance mechanism, give them as a combination, ceftazidime avibactam with aztreonam, it will work out well. There are drugs like tigecycline that could be used in carbapenem resistant enterobacteria. And the recommendations say that polymyxins or colistin are not the preferred agents in CRE, but from the practical experience, they also works relatively okay. So this was a study named Crackle study, where colistin was compared head to head with ceftazidime avibactam in such organism, which showed a good amount of positive result with ceftazidime avibactam. So this is the new drug that is available all over our country or everywhere in Kerala. So it will take care of all these resistance mechanism, ESBL, AMC, OXA, these things will be taken care of. It is a good drug for Pseudomonas also, and it can be safely given in intra-abdominal infection, UTI, ventilator associated pneumonia, and the dosing would be 2.5 gram 8th hourly. But this is not useful. Whenever any new drug comes, our tendency will be to use it everywhere. It won't work in this condition. If the culture is showing Acinetobacter, ceftazidime avibactam won't work. Metallo-beta-lactamases, NDM, ceftazidime avibactam won't work. So in such scenario where you have this NDM production, always you have an option to give two drugs together, that is ceftazidime avibactam along with aztreonam. So the recommendation is to infuse two drugs together. You can infuse via Y connector, or you can put two separate IV line and give these drugs over a period of 2 hours, where it could give better efficacy. This is a new drug that is coming up, cefepime sidibactam. It is not started getting available in our market. This will take care of most of the resistance mechanism. Few case reports of initial use of these drugs is from India, and it keeps working well. It is a beta-lactam enhancer. So coming to the next scenario. So till now I have told about enterobacteriaceae. So in this scenario, the best drugs would be ceftazidime avibactam and aztreonam. Next is 45-year-old man admitted with 25% total body surface burns, needed skin grafting, and after admission the blood culture that was drawn grew Acinetobacter baumannii. And if you see the resistance pattern, almost all drugs are resistant. Colistin is shown as intermediate, and one drug is retaining susceptibility to Acinetobacter, that is cefoperazone sulbactam. So this is one drug that is good in Acinetobacter. It is not exactly, I would say that it is not exactly the cefoperazone sulbactam. It is the sulbactam that is present in this drug that is doing the job. Sulbactam is a very good drug against Acinetobacter. So, how do you treat Acinetobacter? This is a common drug in our ICUs nowadays. Those who are working in critical care ICUs, you might be seeing a lot of this agent in this causative organism in your ventilator associated pneumonia cases. So, we abbreviate it as CRAB, carbapenem resistant Acinetobacter baumannii. How do you treat? So, the Western recommendation would be high dose ampicillin sulbactam, that is at a dose of 9 gram 8 hourly. In Indian scenario, if you are not comfortable with using ampicillin sulbactam, you can try a good dose of cefoperazone sulbactam. You can go up to doses like 3 gram 6th hourly. Other drugs that will work are tigecycline and minocycline. Tigecycline in a dose of 200 milligram loading dose followed by 100 mg BD, and minocycline 200 milligram initial dose followed by 100 to 200 milligram twice daily. So these are the agents that work well in Acinetobacter. And one recommendation is, if you see Acinetobacter, it is always better to give a combination therapy. You can give two agents, whether it could be given with colistin. You can give ampicillin sulbactam along with colistin, or even triple therapy also is suggested in these cases. Tigecycline, the mortality rate has been shown higher in Acinetobacter associated pneumonias, and there no role suggested for nebulized antibiotic, no definite role. I would say maybe some adjuvant role might be there, but nebulized antibiotics is not a big treatment or not a great treatment for ventilator associated pneumonia. So these were some of the studies regarding tigecycline for Acinetobacter pneumonia. That was showing a higher ICU mortality in this case and higher treatment failure rate. So, should you give meropenem if it is a meropenem resistant Acinetobacter? That is the question. You can give meropenem, it is not a recommended thing. But if you are giving, you can give in combination with something like colistin along with ampicillin sulbactam. This is one place where even things like triple drug therapy, 3 drugs for treating one infection, that is recommended if it is a carbapenem resistant Acinetobacter. We might be getting newer good agents like sulbactam, durlobactam. There was an attack trial that was published in Lancet 4 months back. So hopefully we are looking forward to this agent coming into India in the coming years for treating our Acinetobacter cases. So this would be the last thing that I will be dealing with, Pseudomonas. In Pseudomonas nowadays some new terminologies have come. One is DTR, that is difficult to treat resistance, and there is MDR also. So what is MDR? So it is not susceptible to classes like penicillin, cephalosporin, quinolone, aminoglycoside and carbapenem. DTR is a new thing. So how they define DTR is that non-susceptibility to piptas, ceftazidime, cefepime, aztreonam, meropenem, imipenem and quinolone. So if it is non-susceptible to all these agents, then it is said to be DTR, difficult to treat resistance. How do you treat this drug? The drug that I mentioned earlier, that is ceftazidime avibactam, is a very good drug in treating DTR Pseudomonas. And rest of the drugs that has been recommended, except aztreonam, none of them is available in India for time being. There are newer drugs like cefiderocol, imipenem, merlibactam, ceftolozane, tazobactam. All these things are there. Hopefully, these wonder drugs might be coming to India in the next 2-3 years so that this challenge could be addressed. So, in a nutshell of my talk, I would say ceftriaxone, there is no role anywhere in treating these resistant organisms. Ceftolozane tazobactam is a newer drug. It is again not available in India. It is good for Pseudomonas. And only thing that we have in our place is ceftazidime avibactam, which could work in ESBL, AMC, KPC and OXA. But it won't work in NDM mechanisms. So other drugs that could be added to this armamentarium from our Indian scenario would be tigecycline and minocycline. So as a take-home message, I would say ceftazidime avibactam, aztreonam, tigecycline, minocycline. So these would be the agents for treating this organism for the time being in our Indian or Kerala scenario. Thank you.
Thank you, Netto, for the excellent discourse on gram-negative sepsis. Hand over the mic.